Good morning, good afternoon, good evening to everyone again. My name is Bill Savadoff. I'm a principal health specialist at the IDB's Social Protection and Health Division, and I want to welcome you all to the 8th conference in our policy dialogue series on strategies to respond to the COVID-19 pandemic. Today, we're going to be learning about the role that technology has played in the way that Israel has managed the epidemic. We're joined by 4 representatives of the Israeli Ministry of Health who will share with us their experience. The presentation is going to have 3 parts today. The first part will focus on how Israel coped with COVID-19 at the national level, and we'll get an overview of the main measures that the country adopted and what they've found to be most effective in slowing the spread of the virus. The second part is going to emphasize the role of digital solutions in Israel's response, including the importance of the country's health information exchange, which is a data sharing mechanism, as well as the use of telemedicine. And finally, the third part of the presentations we're going to hear today are, will present what they call the Shield. It's an app solution that has been central to Israel's efforts in dealing with the COVID epidemic. So I'm pleased to introduce the speakers. We will have Professor Sigal Sadetsky, who is the head of public health at the Israel Health Ministry. For the last 2 decades, Professor Sadetsky has been the head of the Cancer and Radiation Epidemiology Unit in the Gertner Institute for Epidemiology and Health Policy Research at Sheba Medical Center. And she has a vast experience in research and health decision-making and has made meaningful contributions to promoting and implementing health policies on a wide range of issues. Professor Sadetsky has also worked with leading international bodies such as the World Health Organization, where she's been engaged in supporting crisis readiness in 53 European countries. Our second guest is Itzik Levy, who is the Chief Digital Officer at Healthcare Israel, the international cooperation unit of the Ministry of Health. I'm glad that I was able to meet Itzik before the COVID epidemic started, and when he was able to come to Washington and people were still traveling internationally. In this role, he leads strategic programs for international cooperation in the digital health field with many countries, including China, Denmark, Japan, and Brazil. And Mr. Levy has more than 30 years of experience in senior information technology positions in both the private and the public sectors. Since 2014, he has managed the National Digital Projects sector in Israel's Ministry of Health. The third speaker is Amir Gilboa, the Digital Health Director at Healthcare Israel, the international cooperation unit of the Ministry of Health. He leads all the digital projects between Israel and other countries. Mr. Gilboa has 15 years of experience in IT projects, including nearly 5 years as program manager for 2 national IT healthcare programs for Israel's Ministry of Health, National Emergency Room Program, and Electronic Health Records. He also has experience in managing complex computing projects in the field of national systems. And finally, my pleasure to introduce you to Sari Deshe, the head of the Nationwide Information Projects Department at the Ministry of Health. As head of the department, she's responsible for several national programs, including the Shield app, which is a digital tool that supports the country in tackling the spread of the COVID-19 pandemic. Previously, she was the Director of Research and Development for a clinical decision support platform that deals with drug-related problems. Thank you to all 4 of you for joining us. We're really excited to hear about your experience. I'm sure everybody in the audience is looking forward to these presentations. I want to ask the audience, everyone listening in, to ask your questions whenever they come to you. We have the chat window open. If you click on the Q&A icon, then you can put your question there. Our speakers will be asked to respond to the questions at the end of the webinar. And I'm pleased to say that my colleague Luis Tejerina, who is a sector lead specialist in the bank's Social Protection and Health Division, is going to be available to pick those questions and moderate the discussions. As we're all learning in these new days of virtual events, please keep your mute your microphone on mute, silent, and turn your cameras off, please, to avoid slowing down the connection. So with that introduction, I'm looking very forward to the presentations. I know everybody else here is, and I will give the floor to Professor Sadetsky.
זה מציג, שומעים אתכם? פרופסור סדצקי, אתם רואים אתכם ושומעים אתכם.
אוקיי. Okay, good morning or afternoon or evening, everyone, wherever you are. Thank you for inviting me to present the Israeli experience with the COVID-19 so far. So I will present some descriptive epidemiology of the epidemic in Israel, and I will focus mainly on our policy. Our policy was built of these building blocks that you see here. First of all, very early border restrictions. Since the beginning of the epidemic, when we identified what's going on, we started closing our borders step by step, initially from China, and then from other countries, depending on the risk that we saw in these countries. I will elaborate on this a bit later. Also, from the very beginning, starting from January, long before we had our first patient, we built our laboratory capacity so that we will be able to identify and monitor the situation. Another step was epidemiological, it's still going on, of course, epidemiological investigations for targeted control of chains of transmission to stop the chain of transmission and avoid further infections. And also we are dealing with clusters based on geography, based on institutions for the elderly, because there, of course, the risk is the highest. And in the last, actually, week, when we see, unfortunately, some beginning of the disease, we also focus on educational institutions. In parallel to these steps, we also took steps with social distancing as a complementary step to the focus handling of the chain of transmission. Here you can see our epidemiological curve. As you see, we started actually in the end of February with our first patient, and the epidemiological curve went down. We were very happy to see a rather stable situation, but unfortunately in the last 7 days, we see a rise in our number of cases. 66% of this rise is a consequence of schools, of patients who are pupils in schools, because we opened the schools, and I believe that the steps that we took in the schools are not good enough to avoid further infection. Altogether, we are almost we have passed the 17,000 cases. You can see here the spread of our cases by those who were deceased. Unfortunately, the percentage is 1.7. Those who are ventilated, severe cases, moderate, and of course the vast majority are mild cases. About 15,000 have already recovered, and the rest are isolated, either hospitalized, either in hospitalization or at home. About half of our patients are home patients or in special hotels. So let's talk about the early border restrictions. First of all, Israeli citizens and residents along the period they could and they can enter the country, but they have to go straight away to isolation if it can be managed at home or at special hotels that we open for isolation. And the instructions of what is needed to be done when you get into the airport was spread and disseminated. We did not take the measure of measuring body temperature because of the asymptomatic patient, but all patients were instructed to go to isolation, and if they have any symptoms, to ask to call a special center and order a laboratory test. On the other hand, non-residents were forbidden from entering the country step by step, as I said before, first of all from China, then Singapore, Hong Kong, Macau, and so on, until we actually stopped the entry of every foreigner to Israel because of the pandemic. Each person who needs isolation needs to report on the isolation in a specific internet site, and then we actually monitored the isolation by the police and by other governmental bodies. Also, of course, the HMOs called these people to check how they are and to monitor their physical condition. Home isolation, altogether, we had more than 200,000 home isolations. And these isolations were by law, meaning that it was, we acted, we recruited, and we planned specific laws to enforce all the specific laws that has to do with the pandemic. Laboratory capacity. Our laboratory testing was performed on January 24, and then we expand the number of labs that that are conducting the test during the pandemic. Now we are more than 35 laboratories are handling the tests, and we have passed. We are almost at 600,000. Tests. I think that the rate per million is among the 6 highest in the world. We are now starting, actually this week or the previous week, we started testing antibodies. Of course, there are many scientific questions around these tests, serological tests. Now we are starting a survey of 70,000 people, but we still believe that mainly due to the low positive predictive value of the test, we do not believe that the number of people who have been exposed in Israel past the 5%. Actually, we believe that it is lower than that. So the false positive of the test is a bit high. And this is why we don't think that at the moment we will have much personal clinical value to the test. It is more, it will serve us as a survey, but also in the future, and the more we will learn, the more we will be able to use these results on a personal level. So the early identification of the disease in this step, in the first phase of the disease, we knew where we want to search for our patients. We knew that we want to look at people who arrive from abroad and were in isolation. We knew that we want to identify their contacts. We have an epidemiological investigation for each and every case. The epidemiological investigation takes us about a day and a half from the identification of the patient, and this is how we can test more people and let all their contacts start their isolations. As I said before, we also looked at clusters and we looked at the geriatric facilities, and this is how we knew where to search our patients. But now we feel that it is much more complicated. So our strategy was to discover very quickly, to discover patients quickly, to isolate them. And then, since we were afraid that also we are starting to have community spread, we also took a complementary strategy with social distancing. And then we have also sporadic dissemination. So the social distancing can stop the sporadic dissemination. But what happens now is that we do not have the light anymore. We do not have the street lamp anymore. The social distancing was also stopped because we opened our economy, because schools returned to operate. Also restaurants returned to operate. The social distancing is now very, it is much more difficult to handle the social distancing. Of course, we still recommend personal physical distancing. We have the 3 rules of masks, obligatory masks in public. We have we instruct people to keep their hygienic measures and also 2 meters, to be 2 meters away from one another. But what happens now is that the sporadic dissemination is starting to grow, and it is much more difficult to search and identify these patients. So here you can see the number of laboratory tests, and you can see the percentages, or maybe you don't see it very well, the percentages of positive results out of these tests, which is growing, unfortunately. So what about the social distancing? The social distancing, as I said before, is a complementary strategy to the personal isolation. It was gradual and it was sustained by law. And it took all kinds of, we took all kinds of measuring, as I said, closing schools, restriction on gathering. We started from 5,000 and then 2,000 and then 10 people. Of course, hygiene and sanitation instructions, 2 meter distancing, as I said. We closed the parks, the beaches, the public gardens, and so on. We had restrictions on public transportation. So we took many, many steps in order to create social distancing. And if we look at our the sources of the infection in Israel, we can see that you can see it here, but I'm telling you that about 30% was imported from abroad, mainly from the US, but also from France, Great Britain, Brazil, Spain, and so on. And the reason that the US actually that so much of the spread of the disease was from the US was because while we took very strict measures in closing the borders from all the other countries, we were a bit late in closing the US. So as I said before, we took all kinds of steps for the social distancing. These are some of the dates. As I told you before, it was very gradual, but I will not repeat the exact steps. But from the mid-April, we started opening again, opening the social distancing step by step again. We created a purple stamp to explain how it will be safe to open a business place or a working place, and so on and so forth. And gradually, we opened on mid-May. Actually, we opened on the 17th of May. It is not listed here. The schools completely. Epidemiological investigations, it's clusters. As I said before, one of our measures was epidemiological investigations, which was very fast and efficient and brought to a isolation of patients. We had almost 170 nurses who dealt with it, and they performed it very quickly. Every day we look geographically and search for clusters, for geographical clusters. Here you can see a city with ultra-Orthodox population, which in which the disease was spread all over the city, and we took very extreme measures in this city in order to overcome the epidemic in this place. Throughout the disease, we wanted to protect, of course, our healthcare workers. At the beginning, we took very, very extreme steps, as you can see here. But with time, we got to, we relaxed our strategy a bit. People got used to the disease, less fear of the disease. And actually, right now, here you can see the curve of health workers who were ill. And as you can see, it was only in the beginning. By the way, most of them got infected, not in the hospital, but as a result of returning from abroad or social circumstances. And as you can see right now, we don't have a major problem of infection in the hospitals. We also protected the civil servant. Here you can see a picture from our Supreme Court, from the police, all kinds of staffs, and even our parliament. You can see that there is social distancing, distance from person to person, and mask wearing. So our strategy, to conclude, what was the strategy in Israel? Early border restrictions, rapid upgrading of testing capacity, early and decisive social distancing, early case identification and isolation of case and close contacts, broad-scale rapid epidemiological investigations to isolate people, and guidelines, regulations, and legislative measures to control the whole situation. And thank you very much for listening.
Thank you very much, Professor Sadetsky. We'll switch now to the second part of the presentation, which will be delivered by Itzik Levy. Itzik, you're welcome to start sharing your presentation. And thank you so much. Welcome.
Okay. I hope you can see my screen now. Hi, I'm Itzik Levy. I'm the Chief Digital Officer of Healthcare Israel, and I'm the former head of National Digital Project Sector at the Ministry of Health. I'm honored to be here today and tell you a little bit about how digital health helped Israel fight the COVID-19 outbreak. Just to make sure, I hope you all can see my screen. Luis?
Yes, we can see it.
Okay, great. So Healthcare Israel is a department at the Ministry of Health with a very unique mission. Our mission is to promote a broad and long-standing cooperation between the Israeli Ministry of Health and partner governments, and promote the export of Israeli healthcare system through tri-sectoral collaboration between the government, the health system, and the industry, to develop knowledge, research, and infrastructure in Israel. So, using of digital health tools in Israel didn't start during the COVID-19 outbreak, obviously. About 7 years ago, the Israeli Ministry of Health articulated a digital health strategy for the Israeli healthcare system. It drew a vision and a roadmap for what kind of transformation are needed to be made in our healthcare services that included online health, sustainable health, participatory patient-centered health, preventive, predictive, proactive medicine, and personalized medicine. All of these transformations were needed and identified in order to tackle the 21st century challenges in healthcare systems all over the world. And these transformations are built on top of the data transformations, which you can see in the bottom of the slide, which include EMR and digital documentation at every point of care, interoperability, which has to do with sharing of information between all healthcare providers and integrating the information, and the analytic and research to get insight from all this data. So the Ministry of Health in Israel did not just draw the vision and the strategy, but actually took a very active part. And this is something that, as I said, started a few years ago in building the digital health infrastructures of Israel to allow all the healthcare system move together into the data era. These kind of infrastructures included Health Information Exchange Platform, HIE, Administrative Information Exchange Platform, National Big Data Platform, National Telemedicine Platform, National EHR Platform. And these platforms were made to allow innovation and allow the digital transformation. And this is one of the main pillars of how we wanted to implement our strategy. So I'm going to tell you a little bit about two of these platforms and how they helped us during the COVID-19 outbreak. So first, let me start with our national HIE network. In Israel, we have deployed about 6 years ago a national HIE network, Health Information Exchange, that connects all the hospitals in Israel and all the HMOs in Israel, regardless of ownership. And you know, in Israel, the HMO covers, our 4 HMOs cover about 99% of the residents of Israel. And we also had the Army, the Israel Defense Forces, connected as the 5th HMO. So in Israel, we have already in place a network, a national network that allowed you know, a doctor, no matter where he is in any ER, when a patient admits the hospital, the doctor can get access to all his medical history, including diagnosis, procedures, allergies, intolerances, medication, and so on and so forth. And he can get it from all over the system, no matter where the patient visited in the past, and to give him better treatment. And that's done on a regular basis, on routine. And the fact that we have this kind of network in place, already in place, helped us a lot during the pandemic. And I would like to emphasize 4 specific benefits that we have. First, the fact that we could share patients' clinical information between the various healthcare providers, including the governmental sources like lab results that we got, made us, we could use the HIE serve as a national hub for COVID-19 patients. The second benefit was that gathering the clinical information about COVID-19 patients from all healthcare organizations to the Ministry of Health secured central repository helped us do all kinds of national analytics and dashboards, which I'll present in a few minutes, but helped us get the bigger picture. And when Professor Sadetsky is talking about understanding the behavior of the disease and understanding the clusters and the chain of transmission, the fact that we could collect the information very fast and turn it into insights helped us a lot in understanding what efforts and what research do we need in order to control the pandemic. The third benefit was allowing the Ministry of Health epidemiological investigators, all the nurses that Professor Sadetsky talked about, when they need to have an investigation regarding a specific identified patient, they use the HIE, the information that we could gather from the HIE from all the medical organizations that the patient visited, and get all the medical history of the patient to the investigator. And then he could understand the background disease, if the patient was suffering from COPD, maybe from diabetes, and get all the information and make a much more thorough epidemiological investigation. And the fourth very interesting benefit that we had, you know, we had ad hoc COVID-19 dedicated hospitals that could be in hotels or maybe in hospitals that were converted into COVID-19 dedicated hospitals. And these hospitals did not have, because they were ad hoc hospitals, they did not have any information about the patient, any past information. The fact that we could connect them using the HIE and bring all the information of the newly admitted patients to the doctor in these ad hoc hospitals was very useful for them in giving them the best treatment. So this is the HIE and the benefits that we got from the fact that we have already in place HIE platform. The next platform I would like to talk about is our National Big Data Research Platform. So in Israel, a few years ago, the Ministry of Health initiated a national big data platform that collects information from all over the Israeli healthcare system, then puts it in a central repository as de-identified data, because it's data for research, it's secondary use of data. We have 3 levels of de-identification mechanism in order to protect the patient's privacy. You know, research, unlike primary use of data when you do investigation, in this case, all the data is de-identified. And then we make this data valuable for research to all kinds of researchers that could come from health organizations, government agencies, academy, startup company, et cetera, and we do it using a virtual research room in the cloud where we provide them the tools and the data. So again, this is a national platform that was part of our strategy and was already in place when the pandemic, when we had the outbreak. And it helps us a lot in developing the tools that we call chain of transmission analytics. This tool was developed by the Ministry of Health on top of the operational epidemiological investigation data to assist the public health department monitor the outbreak. So first, we collect the data and we have the statistics. Here you can see, I hope you can, I'll try to switch into laser pointer. We can see the total identified cases. We can see the currently sick. We can see the recovered patient. We can see the diseased. This is updated to 28th of April. This information could be filtered by date, by city, by the origin where the patient came from, if it came out of the country. And it could be filtered by generation, which I'm going to explain in a minute, and of course by the infection source. And you can see here the gender, the information according to gender and according to age. This is the average age, maximal age, median age, and minimal age. But the very interesting information which we had to use all kinds of tools to generate was understanding the levels, the generation, which is the levels of in the chain of transmission, what are the levels of the patients. So we had in generation 0, which are the patients that started the pandemic in Israel, we had about more than 8,000 patients. About, I'm not sure you can see here, we had about more than 1,000 that came from abroad. Then generation 1, which are infected from generation 0, we had over 5,000. Then generation 2, generation 3, etc. So this is very valuable information, very interesting information, but we also wanted to present it in a more visual, graphical way. So, and this is where the chain of transmission analytics come into place. And this is a visual representation of the way people were infected. We collected the information from the epidemiological investigation, and I'm going to zoom in, and you can see these are actual patients. This is patient number 212, and he infected patient 516. This is live data from, it's not updated, but it's real data, and he infected patient 2A21. And you can see the gender, you can see whether this is green, so already recovered patient. Here you can see a patient that is still sick. The infection source of these 2 patients was unknown. We don't know it, though we made the investigation. If you click one of the patients, you can get the information, the age, the date it was identified, the city of origin, the status. And you also can, down here, you have a timeline. On the bottom, you have the timeline, what happened when. And you could also see the Ministry of Health policy changes, which Professor Sadetsky talked about. And you see what effect we had by changing policy to the way the chain of transmission behaved. So these are analytics made using the tools to better control the disease. And we have, the challenge we have here was that data varies among the epidemiological investigation and is not consistent, which breaks the chain of transmission. You cannot understand the chain of transmission and the way the pandemic behaves if the chain is broken because the information is not consistent. So we had to consolidate the inconsistent data using NLP and geolocation algorithms and to visually represent the data and create this chain of transmission, which make it much more easier and valuable for the investigator to understand the behavior where we have a widespread and where we have unexplained cases. So this was just a demonstration of two of the platforms, the infrastructure that we have, the digital health infrastructure that we have in Israel, and how they helped us during the COVID-19. And I'm going to give the floor to Amir Gilboa, who is going to talk a little bit about innovation in digital health and how it helped us during the pandemic. Amir, the floor is yours.
You see my screen?
Yes, we can.
Yeah.
Okay. So my name is Amir Gilboa, and I'm the digital director at Healthcare Israel. I want to thank you, Itzik, and also Bill and Louis, to this opportunity to share our knowledge. In the next couple of minutes, I want to focus on the digital health innovation and the impact of the creative thinking in aim to tackle the COVID-19 challenges. In the last years in the Ministry of Health, the Ministry of Health promote innovation and creative thinking and build strong infrastructure that created benefit to the health organization and the patient. There are two ways of innovation. The first one is innovation from within that meet the challenges in the Ministry of Health and use new models and technology to build the solution in-house. For example, we use open source and community to accelerate development processes. The second one is innovation from outside that meet challenges from of a health system and import tools and technology from other area like the defense platform and make the required customization for the healthcare use cases. With this innovation infrastructure, we meet the COVID-19 challenges. And it was amazing to see the collaboration of all the government agencies and the army units, the health organization, the industry. And I want to present a few examples for the solutions in the three categories. The first one is citizen engagement digital tools. The second one is telehealth and remote care. And the last one is diagnostic tools. The citizen engagement digital tools are an application and channels for the citizen. Some tools aim to deliver official information, and other tools aim to help monitoring and screening. The first one is the Shield app. We use it to recognize the relevant people that notice them if they met anyone has been diagnosed with the coronavirus. Sarit or Mir will talk about it later in the next presentation. The second is a Corona app and the Telegram channel. We use it to deliver official information like instruction for the public, press release, a video with a friendly explanation of complex situation. And I think it's very important to have an official channel to avoid from fake news and to save the citizen informed. And the last example is an application that helps people to understand when they need a Corona test or it's not so urgent. The remote screening app based on questionnaires that direct the users and classify them by the severity level. It helps to reduce the load from the HMO call centers and reduce the patient anxiety. In the field of telehealth and remote care, we see two main challenges. The first one is in the hospitals. When we want to be sure that the medical team is saved, are saved, and we minimize the physical connection between the corona's patient and the team. One of the interesting solutions is the robots. The robots created for completely other use case, and we take it in unique collaboration with the Ministry of Defense and make a customization for the medical team requirement. Now, we use the robot to transfer equipment to the patient, to communicate them by audio and video, and to help in measuring vital signs. We continue to develop a new feature and deliver more robots to more hospitals. The second challenge is to continue the regular treatment in the community clinics or the chronic disease clinics. And in the same time, we want to reduce the load from the emergency department and save on high-risk population. This situation increased the use of Telehealth national platform. And in addition, many hospitals implement a new telehealth solutions. A new research that published in the last days show increase of 65% in patient usage on telehealth services in compared to the time before the pandemic. For many doctors, especially the adults, this change was easy, but in case they not have any choice, many of them tackled this challenge successfully. I think now we will see those changes as something will impact the way of some healthcare services. The last category is the diagnostic tools. And continue to the importance we see in protect our medical team and the need to separate the corona's patient from other patients, we developed the triage radar. This radar mainly use case is in the different force, and together with the Ministry of Defense, we customize the radar to help us make remote triage. We use the radar in the emergency department. When patients start the triage process, the radar scan remotely and report his or her vital signs. If the patient suspected as corona carrier, the medical team can route him or her to the corona department. The distance between the radar and the patient is about 3 meters, so the nurses and the doctors stay safe. The last law I want to present is not a pure digital tool, but I think it's a very interesting. I talk about the corona fast tests. One of our main challenges, as Professor Sadetsky mentioned before, is to recognize and isolate the corona's patient in real time. And when we think about the way we back to normally with the corona until we have the vaccine, the fast test is a very important tool. This kit called Terra, and based on blowing testing. The tester blow into a unique device, and after 1 or 2 minutes, we receive the results, positive or negative. More interesting thing is the test is more specific than the PCR tests. This product is still on a POC, and we work in 24/7 to improve it and to start using it in mass. So we continue work on the solution and the technology you saw today and much more, and to try to help our medical team and of course our patient. Maybe we could help you as well. In one moment, we continue to the presentation on the Shield app, but before I want to continue to take one more minute to talk about our offering. We believe in Healthcare Israel that transformation comes first and that digital technology comes after. While we implement the digital infrastructure project like the Shield or a big data platform, we had to consider other elements, not just the digital and the technology. We must see the whole picture together. And to make successful project, we have to address issues like regulation, privacy, security, incentive, etc. Our digital health offering is divided to 4 service levels and 7 fields of expertise. The first level is document and documentation. Let's say you are interested in the Shield application implementation process. We have a case study document for you. Other documents could be policy documents and so on. The second level is workshop and training in various topics and aspects. For example, we have a 2 weeks workshop focused in digital strategy and cybersecurity in healthcare. The third one is assessment. In this process, our experts team investigates specific digital need in a relevant country and recommend how to improve it. In the end of this process, we provide a recommendation report. The last one is the integrative project, include the whole package, technology, policy, training, till the end of successful implementation. We already start working with Ferdinando and Luis and consider the option to make some of this project together. And I hope we can help each other and to learn from each other to continue in our mission to make the world healthier together. So I want to thank you, and if you have more questions, please write in the chat and I try to answer in the end of this session. And for more information, please feel free to contact Luis and he will let us know how we can help. Thank you.
Thank you so much, Amir. We're running a bit out of time, so I'll skip directly to the last presentation. Our presenter will be Miri Shalev. Miri, while you can set up your presentation, she's the Digital Health Project Manager at the IT Department of the Ministry of Health, and she managed the Hamagen Development Project, which is the application that was presented and she will give us some more details about how the application was implemented in the case of Israel. And Miri, we're very strict on the timing for the presentation, so please go ahead.
Hi. You see my presentation? Okay.
Yes, we can.
Yeah, okay. So welcome everybody. Hamagen app was initiated at the Ministry of Health as part of its efforts to fight the corona and was developed by the Ministry of Health with volunteers, open source community, vendors, and consultants. Its goals is to help fight the spread of the virus by informing the app user about possible exposure to corona, confirmed patients, encouraging him or her to go into isolated, thus minimize the spread of the virus and minimize the likelihood of infects others. This is the government's most successful app yet. It was launched on March 22, and after less than a week, gained over 1 million downloads. In order it to be effective, we must have a widespread, and therefore our goal is to expand to 60% of potential users, taking into account that kids under 16 may not use the app. The app based on GPS location. As you can see, the apps consist of small amounts of screen. Make it simple and not intimidating. We start with how glad we are you joined and that you have a role to play in the fight against the virus. We then instruct you to open location data. We let you choose whether to download your location in the last 40 days by the use of Google Timeline. You can decide to skip it. Then we go to the central screen, which will be the one that is consistently seen in your screen. If you've been exposed, a notification will come up on your notification board on your device. It will let you decide, see that ask, see that's ask you, been there. We ask instead of determine due to accuracy questions. GPS is not that accurate, and also the epidemic investigation is still based on primitive tools such as phone calls. If you know you've been there, you go to the next screen and you can decide what to do with the instructions. See, as we emphasized, that the control is in your hand, but also the responsibility. The app is based a lot of behavioral psychology. We know that we need maximum compliance, and nobody likes to be told what to do, so we work on emotions. Pandemic causes fears. We know that once we had the first young corona patient dead, there will be massive use of the app, so we had to work fast, looking at the upcoming of the second wave. We think it will work the same. When person feels afraid, he needs to be controlled, so having the app help you to control your destiny. Also, you need certainty. The apps allows you to go out your daily routine without being afraid. It will let you know if something happens. Keep it simple, don't distract. People don't need to be reminded all the time. Sorry. 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 Keep it simple. Don't distract. People don't need to remind all the time that they are in a situation, but they will want to know that the app is working. Keep it private is the most important. Nobody likes governments to track him in a very move. He does not, you need to address it. In order to deal with the psychology effects, we based the app on 3 key values. Social, we care about our community, about our family, about our parents, neighbors, and don't want to hurt them. Mutual, if we work together, we can end this epidemic or at least control it. Transparency is in order to massive compliance. We show everything we do. We ask the community, we let them take part in the solution. We don't hide from them. Look at the terms and conditions and the privacy information we provide all the time. How do we gain the public trust? After all, it is a governmental tool. So we open source it, but managing the community. We don't force the public to use it, and we give them two options to erase at all time, and no data will be kept after they erase it. We address the privacy issue openly. All data is kept on the device. Extracting data is only when permitted. We don't even know if you go and notified or not. At the Ministry of Health system, we keep the data of the diagnostic patient's location. A job runs every several hours and upload the anonymous list of location of the Ministry of Health cloud. The app downloads the file and search for a match location and gives an alert if there is a match found. At the epidemic investigation, the diagnostic patient can voluntarily upload his location data by the last 40 days. It raised the accuracy and quality and the investigation. We are working now on our next step functionality, implementing the BLE, Bluetooth Low Energy, in order to accurate the exposure notification. We are facing technology challenges. Knowing that Google and Apple works together and release the API which implement the BLE solution, which not allowed to combine with the GPS solution. Due to that, we decided to get our own solution and not the API of the Google and the Apple. Technology, the distance algorithm is very important. When we start, we thought that we will use 3 layers of information: location-based, Wi-Fi-based, and BL-based. We now know that there is a lot of issues regarding privacy matters with Wi-Fi and using the 2 other resources can get good accuracy on the distance algorithm. Interface wording is very important. We changed it a lot during the last months in order for it to be more precise, asking questions instead of determining. So, data. The accuracy of the app is good at its data. You cannot gain user trust when there are many false negatives. Work on your data. Testing. The regular projects, if in regular project, the testing stage is approximately 30% of the whole efforts, there's here it's more around 50 to 16%. Go out to the field and massive testing, simulate routes, it will make up more accurate. Security and privacy, the name of the game. Take a good consult. You can have a great architect or solution, but privacy-wise, the public influence by opinion leaders that base their opinion on developers of the app will exterminate the plain and simple. Finally, marketing. Don't only use traditional marketing, go to new media approach, use opinion leaders, touch social networks, be prepared to answer questions on very media possible and change. Keep involved and create new versions that fix problems every time. Be agile. Here you can see that Amagen apps get a very high score in security and privacy criteria, and we're very proud about it. Thank you very much.
Well, thank you very much, Miri. Now, we received many questions. I will try to select and group some of them. One issue is that we received some questions about the increased cases in schools in recent days. And the person who was presenting, Professor Sadetsky, is the person in charge of the response for that particular situation. So she was unable to stay with us for the whole time, precisely because of the job she has in responding. I think we have two questions that were more relevant for her, and I don't know if we have in the Israeli team somebody who can say something about that. We were asked about what would have been done differently in the opening of schools. If you can give some more information about the new cases in schools, and what strategies have been used to provide services to pregnant women.
I will try to say I'm not, it's not my job at the Ministry of Health, but I will just give a little bit of information about what happened in the schools. Actually, we first, when we opened the school, we wanted to start with what we call capsules. We wanted to, to bring to class first only half of the students in the class, and then on the other day the other half. But we started with that, and it didn't work. So very fast we moved to bringing all the students together to schools, and very few days afterwards we got again like the reaction like whiplash of again new infected students. The current policy of the Ministry of Health is to close specific schools where we have an outbreak, and not to go back and close all schools. At the moment, I believe, if I read the news today, we have about something around 50 schools all over Israel, which are closed because we had an event of an identified patient. So this is the current policy. We're not, some specialists said that we should go back and close all schools, but at the moment, the policy is just for where we have an identified COVID-19 patient. I hope that answers the question.
Yes, and we will also forward these questions to Professor Sadetsky to get
Sure.
anything else that she might want to complement. But that does give a better idea about what's going on in schools. Thank you so much. The next block of questions were about data, and precisely the things that you and Amir presented. How is data anonymized? What is the strategy for asymptomatic cases? Because we understand from the chain of the disease that you showed that it's based on cases that are detected. So if there was any kind of strategy for asymptomatic cases. And one specific for Amir, if you can tell us a bit more about the tests that the technology that is used to identify the cases in 2 minutes, and maybe a bit more about the robots that you showed in the slide. Thank you.
Okay, so about the data, first about the de-identification or anonymization of data, I will tell briefly, it's a very complicated mechanism made out of 3 levels of de-identification. But generally speaking, we have, as I said, it's something that was already in place while we had the outbreak. It's comprised of 3 levels. First is we have de-identification at the source where the information is sent to the Ministry of Health. Then where we anonymize, IDs in Israel, we have a unique ID for all citizens of Israel. So this part is hashed using the hashing algorithm. Then when the information gets to what we call the reservoir gate, the reservoir is the central repository of the Ministry of Health, the research repository. Then we eliminate all kinds of identifiers like phone number, email, all these kind of specific identifiers. And then when the information is specific information for a specific research is being extracted, then we have all kind of what we call deep de-anonymization mechanism or algorithms where we try to balance between giving the researcher information which is still relevant and valuable, but also protecting privacy. So this is generally speaking about the identification. You ask also about the chain of transmission, how we treated asymptomatic patients. We did not. It means that the patients that we got the information about, and we had the dashboard and the visual presentation which I've showed is regarding patients which went through epidemiological investigation. This is in most cases then does not include asymptomatic patients because we don't know about them. So this tool, this chain of transmission has to do with specific identified patients that we want to understand the spread and how they got infected and understand the behavior of the disease. I hope I answered the question. Amir, the floor is yours.
Yes, Please, if you can repeat the question, you want to
Yes, there were, in your
the robots?
presentation, you showed some technologies that would help to identify cases quickly. In
The blowing test?
Yes.
Okay. And the second question?
More details about how the robot is used.
Oh, so I will start the robots. The robots mainly used to transfer equipment from the nurses to the patients, or from the doctors, or any kind of equipment they want to transfer to the patient, and they can measure vital signs like blood pressure. The devices they can put on the robot arm, and the robot take these devices to the patient, and the patient connect the devices to the arm or to the hand, and the measured connected to a remote telehealth or remote devices that present the measures in the nurse's room. And also they can connect, they can talk to the patients by video and audio, and also the families. They cannot get inside the corona's department, can talk with the patient by the robot video and audio communication tool. I hope this answers the question.
Yes, thank you. And I'll skip to the third block of questions that have to, we received many questions on the application, Hamagen.
Okay.
And I think that some people have actually tried to download it already. And if you can maybe share the link of the GitHub page of the application. I know that the application is the code of the application is open source and available for people to.
I believe, Luis, I've sent it to you in email a few weeks ago, but we will send it again, no problem.
Yes, I have it actually. I just don't want to be the one sharing it, but yeah, if, the code definitely can be shared. People are asking us if the application works outside of Israel. And I do have one question that I want to add. It has to do with the uptake of the application, because we've been hearing a lot of the 60%. And I think everybody's generalizing the 60% for the threshold for being used. And in some of our countries, this is not something that seems achievable. So the question would be, if the uptake of 60% is not reached, does that mean that even that 10% or 20% that will be contacted, is that not useful enough, or what is your point of view about that?
Yeah, you need to understand that when we're talking about, I believe the question refers to the Hamagen app, right, Luis?
Yeah, that's right.
Yeah. So just to better understand, when we're talking about the application, let me just maybe explain in more in details. You know, we have the epidemiological investigation that is done by the ministry. So we have the routes of all the identified patients, all the geolocations of the patients that we identified as the Ministry of Health. When you have the application, this information is downloaded onto your device. And then on the device, without sharing your location information, we do cross-reference between your locations in the past week, 2 weeks, with all the routes that we have downloaded from the Ministry of Health. So even if you have, 10%, 20%, 30% of the citizens downloading the application, you can still get value, because for these users that have downloaded the application, they will get an alert if they have crossed, if they have been, in a supermarket where at the same time where there was an identified COVID-19 patient, and that will tell them you need to go to isolation. So that will still help reducing the transmission of the disease. So the 60% threshold is something to reach, but it's not like a minimum that if you do not have it, you will not get value from the application.
Yes, thank you so much. That's what we've been hearing actually from countries on our side, that even lower percentages are useful.
Totally.
We have gone a bit over time from a lot of time. So I think we answered most of the questions, and the questions that we did not answer were the questions that Professor Sadetsky would be better able to answer. So I would, I already shared the link to the application. I took the liberty to share the link to the application in the chat room if anybody wants to take a look at it. Again, the link is to the code of the application, not to, it doesn't mean that it will work in countries other than Israel, but countries can take a look at the code and adapt it to their reality. We will send the remaining questions to Professor Sadetsky and share to the participants in the webinar. And I want to thank everybody who participated. Thank you for your interest. And Professor Sadetsky, Miri, Itzik, Amir, thank you so much for the excellent presentations. As always, it's been very clear and a very good job, and I think it'll be very useful for everybody who participated. So thank you so much.
Thank you for the time. Thank you for inviting us.